MFN is one of the key trends impacting the pharmaceutical landscape at the moment and is evolving incredibly quickly. So we thought this would be the perfect moment to step back and have a conversation about what exactly is MFN, how it is impacting pharmaceutical companies, and how companies can navigate the changes. To help us chat through this today, we're delighted to welcome Omar Ali, Head of Payers at Verpora. Omar has more than 30 years of experience, including 10 years at NICE. Omar currently works with pharmaceutical and life sciences companies to navigate market access and pricing challenges and improve patient access. So good morning, Omar. Thanks for joining us.
Great to be here, Charlie, and it's a very topical time on a topical subject.
Exactly. So could you maybe just start by just in simple terms explaining exactly what is MFN and what sort of problem is the US government trying to solve with MFN?
Okay, so I think the best way to review it, I mean, most people are listening to this probably heard about it or involved in it, but the overall perspective is from a trade deal narrative. US pharmaceuticals have historically been much higher priced. And really, for decades, the narrative that's coming from the White House administration, this is bipartisan, has been that the US has been subsidizing global drug pricing for quite a few years. And they're really looking to somehow force like a global rebalance, i.e., US has been high price, Europe and other markets have been much lower, significantly lower. And so they want to redress the balance and have the US government pay lower prices and let Europe pick up a higher tab or a higher percentage and really take the pressure for higher prescription and new innovation drug medicine pricing. So the idea is redressing the balance in a trade deal kind of context. There are some issues with it, and we're seeing problems highlighted. I would say because there's too many actors and stakeholders in this game who don't really want that to happen for a number of reasons, and we can go into why that is. But really, if we're talking about the US government spend on medicines, Part B and Part D, the outpatient oral treatments typically, but some injectables, as well as the hospital-administered, physician-administered medicines, Part B injectables, they're trying to reduce the spend that they have. And so it is really a fiscal driver and negotiating on a global level. And we're seeing a lot of elements around how that is both being processed, implemented, and some maybe unintended consequences of it. For the context, I mean, the whole MFN, there was like 19 countries. There was 14 European markets, all the traditional ones, and some extra like Ireland, Netherlands, Norway, Sweden, on top of the sort of European 5. And then we got Canada, and then we have Asia Pacific. There's 4 countries. I think it's Australia, Israel, Japan, South Korea. So you got these kind of sort of 19 nations, and then you got this basket of 8 that are often being referred to, which is Canada, Denmark, France, Germany, Italy, UK, Japan, Switzerland, and it's sort of the second lowest price. So we don't need to go into all the detail, but really this is about redressing the balance, having the US pay less, having Europe pick up the tab and pay more. That's the idea and the notion. And it is really being done like a trade, although I think we often think about this in terms of healthcare and drug pricing. It's done within the context of a trade deal. So there are other encroaching elements like the tariffs, for example. NICE agreed, not NICE, the UK government agreed to increase the thresholds on NICE by 25%. That's like part of a trade deal on tariffs. So there are other interconnecting and underlying elements to this, which make drug pricing now become very hot political potato and contextually potentially very damaging on drug price revenue if it really goes through, which I think we're going to see some trouble with that happening.
Yeah, that's really interesting. Like you said, an incredibly sort of complex picture, a lot of stakeholders. Maybe just from sort of a pharmaceutical company's perspective, I guess maybe could you just comment on what you sort of think the high level changes are that we might see? And again, I guess particularly around, you sort of touched on it there about how we might see shifts in revenue.
So it's not what we might see, it's what we're already seeing, Charlie. And Our team at Verpora, we have supported 7 companies with the IRA CMS drug price negotiation across 2, and we're in our 3rd round. That's going to come into this. And we're currently supporting companies who are actively negotiating against this whole MFN, trying to protect a shield against MFN pulling the prices back. So this is what we're seeing, both from visual reporting as well as being in the room, if that makes sense. If MFN goes ahead with the intention, there's a massive threat, immediate threat to the gross margins of pharmaceutical companies. The US is the biggest market, and then it's European revenue. And that's partly because of the size of the US market, but also the prices that you have in the US. Traditionally, not double or treble, we're talking 4 or 5-fold and even higher. So that threat is very real, because if we see price erosion, the traditional price discounting in Europe, track back to the US, it will be catastrophic to US drug company revenue. I mean, these revenue plummets for new launches, innovative drugs. The second part that's become obvious for those of us who are also working within the US is spillage of this into commercial. So as drug pricing, although this is about, say, CMS and the US government, and maybe not the commercial book of business, there is already elements we have seen in practice and in play. And we've got a healthy network of payers across the globe, around 150 of these, of which significant numbers in the US. And they're also reporting that what is happening within government, Medicare, Medicaid, is spilling into commercial. So, i.e., if the US government are going to get a rebate or discount, the commercial health plans, insurers want that rebate and discount. And how confidential is it? What do those numbers look like? MFP prices are published ahead of time, so everyone got eyes on that. And the final consequence that we're already seeing, and I'll give some examples to this, is what's going to happen to launch sequencing. If a drug company is launching in the US and they want a very high price, and then they come and launch in Europe, and that price tracks back to the US, what's going to happen? Well, firstly, they may not launch in Europe. They may delay the launch in Europe. They may use different obfuscating methodologies. For example, we're seeing increase looking at innovative contracting, maybe value-based agreements, things other than a simpler discount, Charlie, because this simple discounting will be tracked through various mechanisms. A performance-based contract can still be tracked, but maybe under method 2 reporting, probably not under the typical commercial methods that commercial software companies are using. I'll talk about method 1, method 2, we can come to that. But what we're seeing is companies maybe not launching in the US or delay launching. And I think we've already seen that. And we've actually had some companies, Charlie, announce that they're not going to launch and that innovation is going to be stifled. And I personally, I think what happened was the US just presumed that the European countries would absorb the pressure. I mean, look, the same thing has happened with defense, hasn't it? I mean, there's some very good analogies here. The US administration has pretty much told NATO and the European nations, look, if you don't increase what you're paying, then I'm not playing ball. The US is withdrawing. And all the European countries now in NATO are having to increase the defense spending on GDP on the basis of a US kind of policy. And well, this is no different to that. It just happens to be with medicines pricing. The administration wants Europe to pay higher prices so the US can pay less. Now, whereas with defense, I think with NATO, the European countries broadly are in line and they've said they're going to increase at varying speeds. We're not seeing that with the medicines pricing, Charlie. We're not seeing that. And your viewers and listeners and readers will know that already there are some markets pushing back. The governments broadly, it's like the typical single payer systems, they're not sympathetic to this. You know, they're not open arms saying, well, if the US wants to pay less, we'll just pay more. It's not the philosophy, it's not the methodology, and it's actually not the commercial model. And I put this down, actually, it's like a cultural element, Charlie. Healthcare in the US is a business. It's a business. It's about the dollar. Healthcare in Europe is not a business. It's actually a cost center. It's taxpayers' money, trying to get value for money from taxpayers to pay for healthcare. So it's a completely different mindset. So it won't just translate. Historically, Europe has had HTA bodies, single payer governments, aggressively negotiating drug pricing with a single voice. Well, the US doesn't have that. It's a fractured healthcare system. It's based on running up the dollar. I heard once, and I use this in my presentations, the price of the medicine in Europe is the value the medicine will deliver. The price in the medicine in the US is what the market can bear to take. Right? Are you with me? Like,
Yeah.
how high can you go before you break something, and then probably keep pushing higher than that? Two different spectrums and methodologies. So this MFN won't achieve what it's trying to achieve, Charlie, and we're already seeing elements of that, particularly with nations like Denmark and Switzerland.
Yeah, yeah, that's really interesting that you bring up Denmark again, because we've seen sort of Amgen with Repatha, right, and the lawsuit, which I think came out sort of very recently.
Yes.
So yeah, very interesting to see. I guess one question we have, I guess you sort of almost touched on sort of two sort of pathways of sort of the obfuscation and the sort of the not launching. Are there particular drug classes, particular sort of disease areas that you think might be particularly susceptible to, say, drugs not launching?
I think we're going to see it hit the innovative end. And by that, I mean new oncology medicines, rare disease, orphan drugs, and there's other reasons we can add to that. I think the rare disease orphan drug bubble is going to burst personally, but that's my own view. It's going to be these medicines which have traditionally been higher priced in the US by some multiple fold, and often somewhat like if you look at cancer, I mean, cancer is almost traditionally oncology medicine is like a third rail in the US. You know, like they're almost a protected class, aren't they? There are some laws in a certain number of states where you're allowed to try. You can't block access. Europe is used to blocking access. I mean, I worked at NICE for 10 years. NICE or will often say no to a drug. Well, that's kind of unheard of. That's not the US model. You don't say no to anything. Yeah, you have the money, you get access. Like, why? There is no such thing as no. I think the idea of not having access to a new medicine is horrific in the US, but yet European models, that's how it works. That's how they get a good price. And so Denmark, yes, I did see your friend and mine, probably Neil Gruber, reported on it recently. He's a great source for these kind of things. And I think it's the first lawsuit I've seen, maybe that's coming through, and not just on the basis of MFN, actually based on a contractual obligation, right? I think Amgen had a contract for Repatha. I don't know what the timeline was, but the argument is that they pulled out whilst their contract was still running. So that's the lawsuit per se. Switzerland's also looking specifically how its pricing. Now, Switzerland's often had high prices, good access. They pay for their medicines. But I know that the Federal Office of Public Health there is looking at, well, how is our pricing modality going to affect global corridors for pricing across, as it's in really one of those 8 markets. So we're seeing pushback. There's no doubt. And we've seen many companies now. I've seen some of them even say on their price negotiation, not saying this is good value for money, not saying, you know, it might not be cost effective, but this is MFN. I can't accept a low price. Like, I'm stuck here negotiating a ludicrous US type price, and I know it's not going to work for you guys, but I've got no choice because it will track back to the US, and I can't afford that. And if Europe is not going to pay those prices, which I don't think it will, then I think we're going to see launches coming out, withdrawal, new indications. Now, the second method you said is kind of interesting, and that was, we are seeing this as well, personally, from Verpora's perspective, companies now looking at all different methods of trying to get a higher list price at least, and trying to work out a discount that maybe won't fully track back. Now, I'm not saying that you can hide it. You can't. There are two methodologies from which CMS are going to get your net price. The method one is through the commercial software reporting. For example, Eversana through Navlin, IQVIA, Midas. Now that is not, they're not perfect, but they're aggregated pricing models. There'll be some discounts in there and rebates. There might be some lag time on that, and there also probably be some exchange rate elements. So it's probably not perfect, nothing is, but that is the method one. Now, the method two is voluntary reporting. So what the companies are doing is they're buying that same software, they're looking at the price reporting, and they're thinking to themselves, under method one, that's a terrible discounted price. Should we just open our books and do method two? Method two is the company themselves go and volunteer and say to CMS, look, here's our books. This is our aggregated net price. We're sharing it with you. This is the one we want to use. If you do a value-based agreement or a performance-based contract, you're still going to have to report that under method two. You can't really hide it. You might be able to hide some of it, but not really. However, what I will say is some of those complex value-based agreements may not show up on the commercial reporting. So let's say you have a company who managed to get a high list price, use some kind of value-based agreements, which is our kind of sweet spot, and method one doesn't capture it. The Navlin, it doesn't report necessarily that full, because in a performance-based contract, Charlie, think about it. The net price is how good is your drug? Well, you don't know until the contract plays out. Yeah, you don't know. It depends on the success rate. So who knows that price? It'd be interesting. If method one doesn't capture it, you may elect not to do method two. But if you do method two, you've got to open your books. I don't think anyone's going to voluntarily lie to the US government. Does that make sense? Like, that's not an option. So you either say, yeah, we'll go with method one, or you open your books and go method two. Either way, the truth is there's too many actors and players, I think, to facilitate US type prices in Europe. Not going to happen. And there's too many actors and stakeholders that are not going to accept low prices in the US, Charlie. I'll wrap this up with one thing that I would say. If you overnight halve drug pricing in Europe, it's a big win for many people. Maybe not the companies, but the governments would side to win, the patients would side to win, the healthcare institutions would side to win, the taxpayers would get, everyone wins in a way, but the drug companies might lose. If you halve all the drug prices in US overnight, everybody loses. Do you get, everybody loses. What do I mean by that? The actual payers collect a lot of rebate. The PBM mechanisms, they're collecting the difference in the net price and the list price. They lose. The providers lose. The health plan, like the way the US is structured with vertical integration, means that they're all feeding off the rebate dollars. So I think there's tension. Everyone knows drug price is too high. In the US, don't think anyone really wants to lower it, except the patients. Yeah, the patients win. The patient scenario right now, the US they can't afford prices as they are. And the administration really is doing this. The political will is we want to get a reduction in the co-payment that the American citizens are paying for their medicines. Like this is where it started. Is it going to get there? Don't know.
Very, very interesting. No, thank you. I guess one thing, again, we've talked a little bit about what the companies can do, and again, beyond sort of just pushing back, are there sort of ways that they can sort of, I guess, more constructively interact with sort of payers and policymakers?
So they are doing that. So one of the things they're doing is firstly trying to, what are the ways you can get an increase in price in Europe? There's one way to look at it. The ways to do that is through some innovative contracting methods, to looking at the value proposition the product has by generating better evidence than they have traditionally done. That's the only way to get a high price. The methodological HTA process, as a lot of European countries look at, is not necessarily open to a full amount of political will, unless the government is overruling like they did in certain situations. The next thing is looking at how patient groups clinician groups, the guidelines. These are all elements to try and move the drug's value story. The other thing they're going to look at is shielding. How do you launch in Europe and shield any discounting from going back to the US? Like, that's become critical now. And a lot of companies are huddling together. The big thing I think that's really going to revolutionize, Charlie, and I urge your viewers to go and look at this. The JCA has just reported its first dossier. Are you familiar with JCA elements? So, joint clinical assessment, all of the European countries are bought into it. And the idea is, at the moment, HTA is very single. You go to NICE for the UK, you go to Germany for ICWIG, go to France for HAS, you go Italy, IFA. Imagine playing out those negotiations in an open forum. JCA has reported on its first product, kind of damning. And what we now see is Europe, the whole of Europe now is looking at a HTA negotiation wide open. Historically, a drug company might come to NICE, do a HTA argument behind closed doors, have all the weaknesses negotiated behind closed doors, do a secret deal behind closed doors, and then you got access. JCA just opens it up. Everyone can now read the holes in the argument. Everyone can read if there's any uncertainties, which there was, and everyone's now going to use that to negotiate down. How is that going to tie with MFN?
Yeah.
The only way to get a good price now in Europe with the JCA is going to be better clinical trials. That's the only way. Clinical trials that don't have uncertainty, clinical trials will have less uncertainty. It's not always possible to have zero uncertainty, but we know that many trials are designed from commercial risk rather than answering the question. JCA is trying to answer the question. I think it's going to make it very challenging in an MFN environment now.
Yeah, very, very interesting. Thank you. And I guess just as a final question, you know, I think the whole sort of MFN situation feels like there's a huge amounts of uncertainty still. What are sort of looking ahead to the next few years or whatever time period you'd like, what are sort of the sort of key catalysts that are coming up that will sort of, you know, help shape our understanding of MFN?
So the first thing is, I think that at the moment, the problem with MFN is an intersection of many rules. And that, in truth, it's about trade deals. I think we kind of think in our bubble, MFN's about drug pricing. It is. It's about healthcare. It is. But the truth is, if you look at MFN, where it's come from, the US, how they're also doing IRA, CMS drug price negotiation. We got GUARD, Globe, Generous. There is a mash of interactions between the US government, what they're trying to do internally, and the ripple effect externally, globally. I sense in the short term, the reality will be delayed launches and maybe even an absence of some launches. I noticed recently companies now becoming much more vocal about the threat to innovation, particularly in Europe. We're seeing companies at the moment coming up very public about Germany. In fact, some of them German companies saying that Germany is not going to be a good launch environment. And Germany historically has had, like, you know, free pricing for 6 months, seeing how it goes, even though it's been, you know, ICWIG and AMNOG is not easy to navigate. So I think we're going to see a change in the launch sequencing. Now, if this is bipartisan, which means I think the companies are going to be waiting for this 2.5 years or whatever we have to see what's going to happen. I don't think we'll necessarily lose a lot. We'll have achieved quite far down this road. How are companies going to negotiate this? The other element is outside deals. Like, are there elements of trade deals that the US companies might do, and global pharmaceutical companies might do with the US to try and circumnavigate, like they do with the tariffs and like they do with other elements of trade that might go broader than just a HTA price? When I look at what happened in the UK with NICE, NICE hasn't moved its cost per quality threshold since its inception. But it changed recently. Why? That was US administration. And it wasn't US administration of MFN, it was the trade deal of tariffs that did it. And it was actually in trade of tariffs on pharmaceuticals that got the UK government to increase an ICE threshold. It wasn't NICE's decision, it was UK government decision. So I wonder whether some of this is going to play out at a higher level than the drug pricing political play, if that makes sense. So broadly, what I sense is in the short term, a changing dynamic to the rhythm of drug launches, indications, potential withdrawal delay, increase in innovative contracting to do some level of obfuscation, not complete, but some, potentially launching in the US first and leaving other countries for a while, getting a foothold. So there is no reference price to come back. You can't do an MFN if you haven't got a price in the basket countries, right? So what's your price? It's just what you launch in the US. Now, the MFN price may come back to haunt you afterwards. So you might delay launch for 3 years, see what happens with the new administration. The Europeans won't be happy with that over time. Although we're used to not having certain products, there's going to come a time when Europe goes, listen, we haven't had any of the latest cancer drugs. We haven't had any of the latest gene therapies. Like, we're losing out. That voice will grow. But at the same time, I can tell you now, if you look at the US healthcare system and what I said, the US healthcare is a business. There are many stakeholders, including the healthcare industry there, of hospitals, providers, plans, PBMs, don't want to see that reduction in drug price, really. Not really. And at the moment, they're so dependent on it that to adjust needs a level of phased approach. You can't just suddenly blanket this. And if I would like to add in closing, if I may, it's clear to me that the US does need some way of valuing its medicines, like maybe a new framework. And CMS has gone some way to addressing that. What the US doesn't need is a copy and paste on Europe, because the US healthcare industry is not like the European healthcare industry. So I get that they want lower drug pricing, but you don't just copy and paste. I'll give one good reason for that. When we supported drug companies with their CMS drug price negotiations, it's clear in the statute that CMS doesn't use QALYs. You're not meant to use QALYs, and there's no element of QALY discussion or negotiation in that room. Yet with MFN, you're copying and pasting prices of many countries that do use the QALY. It doesn't make sense, does it, Charlie? So I think the copy and paste doesn't work, but I think the US does need to find its value framework that suits its healthcare market, suits its citizens, and can allow pharmaceutical manufacturers to play at a global level so that we still have access to innovation in our own ways.
Really interesting. Some very large scale changes on both sides of the pond, I think. Oh, fantastic. Oh, thank you so much for your time, Omar. That was, yeah, really very interesting. Thank you.
It was a real pleasure.